Hi, there's a power cut in my home. I'll not switch on the camera, but I can start the class actually. I can start the class and go on. And when the power comes, then I'll probably switch on the camera so that the internet is, you know, adequate to conduct the class. Otherwise,
Please start the classroom without camera only. Once the current comes, you can switch on the camera.
yeah, sure, I'll do that.
Right.
Just hold on, I'm sharing the screen. Okay, I'll start the class. Right. Hi, guys. This is Dr. Sushma, your anatomy educator here at Auricle. And today we have come to the last class of embryology in which we are studying about the male genital system. Okay. Yes. So we here at Auricle offer you we here at Oracle, we offer you these core features where we have live classes, recorded session, notes, as well as MCQs. Sorry, what is happening? Notes as well as MCQs. These live classes are based on the educator who comes and teach everything online to you, and the recorded sessions have the videos which are already recorded, and basically if you haven't understood something in the live classes, you can always go online and study them from the recorded sessions. And we also have notes which are based on the recent CBME curriculum and MCQs that will help you to ace your upcoming next examination. Okay. Yes. And you can also book a slot for a personalized counseling session with us where you'll be given a mentor, and that mentor will help you to just hold on, guys. Just hold on. Just give me 1 second. Hi, I'm sorry. The power came back due to the switch. Just a second. Let me just share the screen. Please let me share the screen. Hi, guys. Good evening. This is your anatomy educator here at Oracle, and today we have come to the end of the embryology sessions. Today we have reached the male genital system, and today we'll study the development of the male genital system. Okay. Yes, and we here at Oracle offer you four core features wherein we have live classes, recorded session notes, and MCQs. In the live classes, you have the educator who comes online and teaches everything online, and in the recorded sessions, all the sessions are recorded, and these are pre-recorded sessions which you can utilize. And you can utilize these sessions. And if these sessions are basically of very good quality, they contain precise amount of information that you actually need. And you of course have notes which are based on the recent CBME curriculum and the MCQs, which will help you to ace your entrance examinations. We also offer you personalized counseling sessions in which you'll be given a mentor, and they'll be like your friend and a teacher who will give you who will give you required input that you need, like making a study plan or telling you where you lack or clearing some concepts for you and everything. You can also have these four subscription plans that we offer: basic, standard, and the premium plan. In the basic plan, you have pre-recorded live and quick revision exam modules. In standard classes, along with them, you have live doubt clarification as well. And in the premium plan is like all in one kind of a plan where you have everything, including one-on-one personalized guidance as well. Okay, this is the tentative schedule. And in today's class, we will be doing the male genital system development. All right. Yes. Before starting, let me just see why my stylus pen is not working. Just a second, guys. Yeah, right. Sorry. Okay, so today we'll be studying the development of male genital system. Okay, yes. A 6-month-old infant is brought to the pediatric clinic for routine checkup. Okay, his parents express concern about his genitalia. Upon examination, you notice bilateral, non-palpable testis. Okay, what do we have? We have bilateral, non-palpable testis. The rest of the physical examination is unremarkable. What is the common, most likely diagnosis of this infant's condition? This is a condition in which the testis have not descended into the scrotum, and it is called as cryptorchidism. Cryptorchidism is a condition where the testis fail to descend to the scrotal area. And what is hypospadias? If you look at it, guys, in the penile shaft, the urethra is actually placed more anteriorly. It is the most anterior most structure that is there. If you look at the shaft of the penis in hypospadias, this urethral will be opening will be present elsewhere, not where it is supposed to be present. It may be present here, it may be present here, it may be present somewhere here. This condition is called as hypospadias. Phimosis is a condition in which the foreskin is not able to get retracted. Physiologically, phimosis is still okay. In developing kids, it is still okay up till 3-4 years. But after that, the foreskin should be able to retract easily on the glans penis. And now, looking at the clinical scenario, the answer is undoubtedly cryptorchidism. Now, let's look at how the sex differentiation actually takes place. Okay, I told you the embryo that is formed, right? It is actually bipotential, correct? It can either become a male or it can become a female. Now, what decides that a particular embryo or a particular zygote becomes a male or a female? What decides is the Y chromosome. In the Y chromosome, there is a gene called as SRY gene, which is called as sex determining gene on Y chromosome. So the SRY gene, which is present on the Y chromosome, decides the sex of the baby. If Y chromosome is present, it is a male fetus. If Y chromosome is absent, it is a female fetus. As simple as it gets. Okay. Now, under the influence of SRY protein, that is the gene, the male development occurs. In its absent, female development is established. Okay. The sex of the embryo is determined genetically at the time of fertilization, but the gonads do not acquire male or female morphological characteristics until the 7th week of development. See, when the fertilization happens, let's say it is XY, the female's male, the gamete is XY and the female is XX. All right. When the fusion of these two gametes happen, we have two combinations possible. Either it can become XX or it can become XY. Okay. At the time of fertilization, the embryo, sex of the embryo genetically is determined. Okay. But the gonadal development eventually, it may, gonadal development do not acquire male or female morphological characters until the 7th week of development. Embryo may have any sex, during genetically it may be of any gender at the time of fertilization. But what determines the sex of the embryo is actually the presence of SRY gene. If it is present, the gonad becomes a male. If it is absent, the gonad becomes female. Which hormone is primarily responsible for the differentiation of male genitalia during embryonic development? Undoubtedly, testosterone. Undoubtedly, testosterone. Okay. Now, during the 5th week of a thickened area of mesothelium develops on the medial side of mesonephros known as genital ridges. Guys, just a question to you. I know all of the, the urogenital system, it develops from the mesoderm. Urogenital system develops from the mesoderm. But in the mesoderm, we have 3 different areas. We have paraaxial mesoderm, we have intermediate mesoderm, we have lateral peak mesoderm. Out of these 3, the genitourinary system comes from which mesoderm? It's a thing that we have already covered. Genitourinary area comes from the intermediate mesoderm. Okay, whatever genital ridge and anything and everything that is formed here, is all coming from the intermediate mesoderm. The genital and the gonadal ridges are a pair of longitudinal ridges which are formed by the proliferation of mesodermal epithelium, condensation of the underlying mesenchyme. Germ cells do not appear in the genital ridges until the 6th week of development. These germ cells are the ones which are going to form the gonads. Okay? Yes. Next, what are primordial germ cells? Primordial germ cells are also called as PGCs. Let's call them PGCs. Okay. Now, PGCs originate in the epiblast and migrate through the primitive streak. By the 3rd week, primordial germ cells reside among the endodermal cells in the wall of the yolk sac close to the allantois. Okay, you can see if this is the allantois, by 3rd week, these PGCs, they reside in the endodermal cells in the wall of the yolk sac. This is the wall of the yolk sac, and this is where the PGCs are existing. Okay. Then during the 4th week, they migrate by amoeboid movement along the dorsal mesentery of the hindgut. In the beginning of the 5th week, the PGCs arriving at the primitive gonads. So when are they arriving at the primitive gonads? At the beginning of the 5th week, and the 6th week, they are invading the genital ridges. Okay. Now, PGCs have an inductive influence on the development of the gonad into ovary or into testis. It can see until now, the gonad that the baby has, that the embryo has two potentials. It can become a testis also, it can become an ovary also, but genetically, whatever may be the gender, it may be XX or XY, doesn't matter. But now it has the potential to become both. Why? Because the PGCs that are coming over there have the potential to become both. Okay, that is the concept. At the time of fertilization, guys, genetically, whatever may be the sex of the embryo, but what determines the development of the internal and external, the reproductive system and so different organs is the SRY genes and different hormones. Okay, if they fail to reach the ridges, the gonads don't develop. So the PGCs are the ones that are influencing spermatogenesis as well as oogenesis. Okay, spermatogenesis and oogenesis that are happening in the gonads is actually influenced by the PGCs. All right. Now, shortly before and during the arrival of the PGCs, the epithelium of the genital ridge proliferates and epithelial cells penetrate the underlying mesenchyme. And here they form a number of irregularly shaped cords called as primitive sex cords. Both male and female embryos, these cords are connected to the surface epithelium and it is impossible to differentiate male and female. Hence, it is known as indifferent gonad. Whatever may be genetically sex of the embryo could be anything. Okay, it may be XX or XY. Even in the 6th week of development, I do not know what the kind of gonad is it going to be. Okay, it may be anything. After the fertilization, it may be XX or XY. It's a genetical. But phenotypically, what the sex of the gonad is going to be, I don't know, because even now, the end of 6th week also, it is a bipotential gonad. Okay, it's a bipotential gonad. And here you can see the primitive sex cords which are present here. All right. Yes. Next. Before we go into this particular slide, let me just teach you the development of testis. Okay. So first of all, what we need to understand, guys, is we have an external genital system and we have an internal genital system. Okay, what are the external genitalia that we have? Example, in a male, it is the penis, it's a scrotum, right? And in females, it is labia majora, labia minora, and there is vagina, and there is clitoris, the vulval region. So all of this is external genitalia. 1/3 of vagina, okay, upper 1/3 of vagina. So all of lower 1/3 of vagina. All of this is external organs of male and female. The internal genitalia of male is there is prostate, right? There are seminal vesicles. There are bulbourethral glands, and in female you have uterus, you have fallopian tube, there are ovaries, and cervix, and the upper one third of vagina. So these are all the what are internal genitalia of a female. Okay, now understand one thing, guys. If SRY gene is present, what did I tell you? SRY gene is present, it leads to the development of testis. Now, testis has two different types of cells. Okay, we have Leydig cells and Sertoli cells. We have Leydig cells and Sertoli cells. Now, Leydig cells produce two hormones. One is AMH, which is called as anti-Mullerian hormone. Another is the testosterone. Okay, AMH and the testosterone. Now, AMH that is produced by the Leydig cells regresses the Mullerian ducts. If, as I told you, the embryo that we have is bipotential, it can become a male or a female. Leydig cell secretes AMH, and the AMH makes sure that the female Mullerian duct is not getting produced. Whereas the testosterone produces the Sertoli, it stimulates the Sertoli cells to produce and convert testosterone into dihydrotestosterone, and which eventually results in the formation of male external genitalia. Male external genitalia. Okay. Yes. So this is how the male external genitalia system development takes place. If testosterone is present, guys, it results in the formation of male external genitalia. This is the concept. Let's look at it. If the embryo is genetically male, the primordial germ cells carry an XY sex chromosome complex. Under the influence of SRY gene on Y chromosome, the primitive sex cords continue to proliferate and penetrate deep into the medulla to form the testis or medullary cords. Towards the hilum of the gland, the cord breaks up into a network of tiny cell strands that later give rise to rete testis. During the further development, a dense layer of fibrous connective tissue, the tunica albuginea, separates the testis cords from the surface epithelium. In the fourth month, testis cords become horseshoe-shaped and their extremities are continuous with those of rete testis. Okay. Now, what is the structure of testis? It is now composed of primitive germ cells and sustentacular cells of Sertoli derived from the surface epithelium of the gland, and it produced Mullerian inhibiting hormone, that is anti-Mullerian hormone. Okay. Yes. Interstitial cells of Leydig, which are derived from the original mesenchyme of the gonadal ridges in between the testicular cords, they begin development shortly after the onset of differentiation of these cords. By the 8th week of gestation, Leydig cells begin they begin the production of the testosterone, and the testis is able to influence sexual differentiation and the genital ducts, and it forms the external genitalia. Are you understanding, guys? Are you understanding? What did I tell you? What did I tell you? Testosterone, Leydig cells produces the testosterone, which will influence the Sertoli cells, and it gets converted into dihydrotestosterone, and then external genitalia of the male is formed. Okay. Now, this testis cords remain solid until puberty, when they acquire a lumen and thus forming the seminiferous tubules. All right. Once the seminiferous tubules are canalized, they join the rete testis tubules, which in turn enter the ductuli efferentes. This efferent ductules link the rete testis and the mesonephric and the Wolffian duct, which becomes epididymis and ductus deferens. Okay. So, the male duct of reproduction is the Wolffian duct. It's the Wolffian duct. Okay. Or it's also called as mesonephric duct. These are all basics, guys. I mean, I presume that you already know all of this. That's why I'm going into things which are important. All right. Yes. Now let us look at the descent of the testis. Descent of testis is a very important surgical topic, and let's just go through this once. Extending from the caudal pole of the testis is a mesenchymal condensation known as the gubernaculum. Where is it coming from? It's coming from the caudal pole of the testis. Okay. Now, this band of mesenchyme terminates in the inguinal region, and an extra abdominal portion of the gubernaculum forms and grows from the inguinal region towards the scrotal swellings. If this is the inguinal area, guys, let's say there's a superficial ring and the deep ring, whatever the gubernaculum that is there, it terminates in the inguinal region. From here, it has to further descend down and come to scrotum. Okay. Then from the inguinal region, an extra abdominal portion of the gubernaculum forms and grows from inguinal region towards the scrotal swellings. Normally, it takes the inguinal region by approximately 12 weeks of gestation, and they migrate through the inguinal canal by 28 weeks and reach the scrotum by 33 weeks. Meaning at around 12th week of gestations, testis enters the inguinal canal and then migrate through the inguinal canal by 28 weeks, and by 33 weeks, it reaches the scrotum. Just a recap, guys. The boundaries of inguinal canal. Can anyone tell me what are the boundaries of the inguinal canal? It's very, very important. Anterior wall, just a recap. You know, it's very, very important. Will be asked in your exam. Anterior wall is made up of external oblique aponeurosis and internal oblique. Isn't it? Internal oblique. Is it or is it not? Lateral 1/3 is internal oblique. You have to tell me this because it's a very, very important question. Posterior wall, throughout it is made up of transverse fascia transversalis. Is it or is it not? You have to tell me this. Fascia transversalis. Anterior is done. Posterior is done. Roof is made up of lateral 1/3. It is made up by the arched fibers of the internal oblique and the transverse abdominis. What tendon is coming from the transverse abdominis? Conjoint tendon that is forming the roof. Floor is formed by inguinal ligament. So this is something which you can never forget, guys. Now, the superficial ring is a defect in what? Superficial ring is a defect in what? Deep inguinal ring is a defect in what? You will have to tell me. Deep inguinal ring is fascia transversalis. Superficial ring is external oblique aponeurosis. This is something which you cannot forget. This is something you cannot go to exam without studying. Okay. You will have to know thoroughly. Inguinal canal is so much important. Okay. These are the boundaries and the walls of the inguinal canal. Just a small recap that we did. But you have to know this, guys. Right. Next. This process is influenced by so many hormones, especially the androgens and MIS. Then the testis descend through the inguinal ring over the rim of the pubic bone and present in the scrotum at birth. Okay. During descent, the blood supply to the testis from aorta is retained and the testicular vessels extend from their original lumbar position to the testis and scrotum. Now, what are the coverings of testis, guys? This is again very important. Now, the peritoneum of the abdominal cavity forms an evagination on the side of the midline into the ventral abdominal wall. Okay. Now, this evagination, which is called as the processus vaginalis, follows the course of the gubernaculum and testis into the scrotal swelling. You can see, guys, you can see here how this evagination is formed. Invagination is into the tissue. This is called as evagination. Now, this evagination, you can see the descending testis like the testis is going, and the one that is attached is the mesenchyme, which is called as the gubernaculum. Now, this gubernaculum is going through the inguinal ligament along with the testis and the gubernaculum. The one that is going along with it is called as processus vaginalis. It's called as processus vaginalis, which is which is nothing but peritoneum, which is nothing but peritoneum. Correct? The peritoneum of the abdominal cavity follows the testis, which is called processus vaginalis. Okay. Next, hence the process of vaginalis is accompanied by the muscular and facial layers of the body wall, evaginates into the scrotal swelling, forming the inguinal canal. Understanding how the inguinal canal is formed? Inguinal canal is formed by the same contents, by the same structures that form the body wall, because as the process vaginalis is descending down with the testis, it is bringing the structures of the body wall along with it through the inguinal area that forms the inguinal canal, and that is why you have all of these muscles: external oblique, internal oblique, fascia transversalis. These are all the muscles of the abdomen, isn't it? Muscles of the abdominal area. Why are they forming the roof, wall, and the floor of the inguinal canal? Because developmentally, when the processus vaginalis is coming down like this, it is also bringing the contents of the body wall, or sorry, the structures of the body wall, and that forms the inguinal canal. Okay. Now, which of the following structures is formed by the labio-scrotal swellings in male? Which of the following structures is formed by the labio-scrotal swellings in male? The answer is scrotum. It is there in the question itself. Then the testis is then covered by a reflected fold of processus vaginalis. So entire thing along with the processus vaginalis, the structure of the body wall is coming, and the testis is covered by only one of the reflected covers. That's it. Then the narrow canal connecting the lumen of the vaginal process with the peritoneal cavity is obliterated at birth. What is happening, guys? If this is the peritoneum, okay, this is the peritoneum and the body wall. Now we have entire peritoneum and the body wall following the testis, and of course a communication is developed between the, if this is the testis, okay, this is the testis, and then let me just use a different ink here. This is the testis now, and what is it covered by? It is covered by this peritoneum, entire reflected part of the, okay, reflected part of the, and this is called as the processus vaginalis. The testis is covered by this processus vaginalis. Now the canal that is connecting the lumen of the vaginal process and the peritoneal cavity is obliterated at birth. Otherwise, what happens? Any of the content in this peritoneum can come and it can encircle the testis, and it can cover the testis like this, which forms something called as hydrocele, which if this cavity is not obliterated, then it causes hydrocele, which you will study in your surgery classes. Okay. In addition, the testis become ensheathed in layers derived from the anterior abdominal wall through which it passes. Okay. From anterior abdominal wall, enters into the inguinal canal by 12th week, leaves the inguinal canal by 26th week, and enters into the scrotum by 33rd week. Understood? Understood? Yes. This is a very important thing, guys, because you can see the formation of the gubernaculum here. Testis is present over here. So gubernaculum is like a guide wire. You know, it is leading the testis. Okay, tu idhar aaja abhi. Okay, I have come here, and you come now into the inguinal canal, and now you come into the, in this, it is entering into the scrotal area, and which is covered by the tunica vaginalis. See this, guys. See this. In this, as the testis is passing through the anterior abdominal wall, it is also entering the inguinal canal and bringing all the structures of the anterior abdominal along with this. Look at this bluish color descending down through the inguinal cavity and forming the inguinal canal and covering the testis. But you can see here in this picture, which is the adult testis, the canal, the communication that is existing between the tunica vaginalis and the anterior abdominal cavity is gone. If it is present, the contents of the abdominal wall can come over here also like this. They can herniate like this, and they can cover the testis. Is it or is it not? It is a possibility, right? Why does it not happen? That we will see. Okay? Yes. Now, clinical correlation, that is hernias and cryptorchidism. Now, connection between the abdominal cavity and the processus vaginalis in the scrotal sac normally closes in the first year after birth. If this passage remains open, the intestinal loops may descend into the scrotum, causing a congenital indirect inguinal hernia. Sometimes obliteration of this passage is irregular, leaving small cysts along its course. Later, these cysts secrete fluid and forms a hydrocele of the testis at the spermatic cord. Now, as I keep telling you guys, this is the anterior abdominal wall, and the testis is coming here from the anterior abdominal wall to the scrotal cavity, and along with that, it, as the testis descends down, it brings the anterior abdominal wall with it. Okay, and it, as it reaches here, it is now only covered by one structure, which is processus vaginalis, and the cavity between the processus vaginalis and the anterior abdominal wall should be obliterated by 1 year. If it does not, what happens is contents of the abdominal wall like intestines or anything, mesenchyme, peritoneum, anything can actually herniate through this and form the inguinal hernia, indirect inguinal hernia. Direct inguinal hernia, guys, comes from the Hasselbalch's triangle. What are the boundaries of Hasselbalch's triangle? Laterally, we have inferior epigastric artery. Medially, what do we have? Oblique aponeurosis, and this is inguinal ligament. Correct? And Hasselbalch's triangle, whatever the structure that comes medial to the inferior epigastric artery, forms the direct inguinal hernia. Sometimes obliteration of this pathway, when it is irregular, it forms cysts over here, which will secrete fluid, and that fluid trickles down into the tunica vaginalis and it forms hydrocele. Okay, 99% of the male newborns testes are present in the scrotum before birth, but most of the remainder descent will be completed during the first 3 months postnatally. However, if in 1% of infants, one or both testes fail to descend, then it is called as cryptorchidism, may be caused by decreased androgen production. Okay, now this undescended testis fail to produce mature spermatozoa, and most importantly, it is associated with seminoma. Okay, it can turn cancerous. So that is why surgeries are done in case of cryptorchidism. Failure of testis descend in the scrotum during development is called as, just now we did, cryptorchidism. Cryptorchidism. Right. Genital, ductal, in different stages. Okay, initially both male and female embryos have 2 pairs of genital ducts, which is mesonephric duct and paramesonephric duct. Wolffian duct is what? Male. Mullerian duct is female. Mesonephric duct is the Wolffian duct. Okay, it consists of mesonephric duct, gives rise to everything: epididymis, vas deferens, seminal vesicles, and ejaculatory duct. Okay, mesonephric tubules, which are called the epigenital tubules, gives the epididymis. Paragenital tubules gives rise to paradidymis. Okay, now as the mesonephros regresses, the epigenital tubules establish contact with the cords of the rete testis and finally form the efferent ductules of the testis, whereas the paragenital tubules along with the caudal pole of the testis do not join the cords of the rete testis, and their vestiges are primarily known as paradidymis. Okay, this may be asked as just a short note, guys, but not very important. Right. Now, external genitalia in different stages. By the 3rd week of development, mesenchyme cells around the cloacal membrane form a pair of slightly elevated cloacal folds. Okay. Then, cranial to the cloacal membrane, the folds unite to form the genital tubercle. Okay. From the genital tubercle, we have different structures coming in. Okay, these swellings, genital swellings, later form the scrotal swellings in male and labia majora in females, which are another pair of elevations. There is a genital tubercle and genital swellings. Okay, genital swellings actually gives rise to scrotal swellings in males and labia majora in females. Okay, end of sixth week, it is impossible to differentiate between the two sexes. That is, it is still bipotential gonad. Okay, yes. Now look at this, guys. Look at this diagram. So this is where the urethral outlet is, and this is the structure of a male, adult penis, and this is the glans, and this is the line of fusion of the urethral folds and line of fusion of the scrotal swelling. So that is why urethral outlet is present on the midline, and this is the perineum, and here is the anus. Okay, yes. Next, development of male urethra. Not very important for you guys, just for the sake of completion. The pelvic part of the urogenital sinus in the male gives rise to prostatic and membranous parts of urethra. As we know, urethra has two parts, right? There is a prostatic part, there is a membranous, sorry, there are four parts. I'm talking about the inner ones, right? Next, the epithelium of the urethra in both sexes originates in the endoderm, and the surrounding tissue and the smooth muscle tissue is derived from the visceral mesoderm. Are you getting any correlation here? Epithelium is deriving from the endoderm. Why, guys? Because lateral plate mesoderm along with endoderm forms the lining of gut and urogenital structures. This is such an important concept. This we had a correlation even while discussing about the rectum and anal canal in the yesterday's class. Okay. At the end of the third month, epithelium of the prostatic urethra begins to proliferate and forms a number of outgrowths that penetrate the surrounding mesenchyme. In males, these buds form the prostate gland. Okay. Now, this is important, guys. Why? Because in hypospadias, what happens? The fusion of the urethral folds is incomplete. Okay. And abnormal openings of the urethra occur along the inferior aspect of the penis, usually near the glans penis, along the shaft, or near the base of the penis, and incidence is around 3 to 5,000 births. Okay, if urethral opening, as you can see, is subcoronal here, and here it is mid shaft. This is where the urethral opening is, and somewhere in this it is penoscrotal. There is no urethral opening in the glans penis at all. Look at this, it is penoscrotal. Okay, this is called as hypospadias, where the urethral opening is present in the posterior or the inferior aspect of the penis. If the same urethral opening is present on the superior aspect, then it is called as epispadias. Epispadias is again a rare abnormality in which the urethral meatus is found on the dorsum of the penis. Although epispadias may occur as an isolated defect, most often associated with exostrophy of the bladder. What is this called? Exostrophy of bladder, I explained in previous class. Ectopia vesicae. Okay, ectopia vesicae, where all of these are very common. I told you, clitoromegaly and labia majora, which are separated in female, and epispadias in male, very common. Okay, which is due to the abnormal closure of the ventral body wall. What are the other two conditions we discussed? One was omphalocele, the other was gastroschisis. Which has a better prognosis? Gastroschisis has a better prognosis, even though it looks bad. Omphalocele is associated with, it is associated with Down syndrome, many trisomies, right? Trisomies 15, 18, 21, right? 13, 18, 21. And omphalocele is also associated with Beckwith-Wheaton syndrome. Okay, you should be remembering all of these things. Correct? Very important things, right? Yeah. Then we have a condition called as micropenis, occurs when there is insufficient androgen stimulation for the growth of the external genitalia. Micropenis is usually caused by primary hypogonadism, hypothalamic or pituitary dysfunction. Bifid penis or double penis may occur if the genital tubercle itself splits. Okay, let's take a small MCQ. The condition characterized by incomplete fusion of urethral folds resulting in an abnormal opening of the urethra and the ventral surface of the penis is epispadias. spadias. If it is on the dorsal surface, then it is called as hypospadias. Hypospadias. So this is how the development of the genitourinary system takes place. So just to summarize, guys, when the fertilized, let me just take a new paper. Okay. When the fertilization happens, right? When the fertilization happens, genetically, it may be XX or XY. The sex could be anything. But till 6 weeks, the gonad that is there is bipotential, right? It can become a male or a female. When the PGCs come to the gonads, the primitive germ cells, they influence the gonad to either become a testis or a ovary. In the testis, we have two different types of cells. Okay, we have Leydig cells and we have Sertoli cells. Leydig cells secrete AMH, which is anti-Mullerian hormone, and also they secrete the testosterone. Okay, testosterone. Anti-Mullerian hormone regresses the Mullerian duct and it prevents the gonad becoming ovaries. Okay, and it prevents the Mullerian duct and whatever the derivatives that were there from the Mullerian duct. Now testosterone now goes and stimulate the Sertoli cells and it gets converted to dihydrotestosterone. Once dihydrotestosterone is present, the external genitalia that is formed is male. So now we have a male external genitalia, and because AMH is regressed, the internal genitalia formed will also be male only. Okay, that's all you need to remember. Internal genitalia that is formed is male. Why? Because AMH is regressing the Mullerian duct. External genitalia formed is also male. Why? Because testosterone is present. Then we studied about the descent of testis. Descent of testis, it comes from the abdominal cavity to the inguinal canal to the scrotum. Enters inguinal canal at 12th week, comes out at 26th week, and comes into the scrotum by 33rd week. As it comes down into the inguinal canal, it brings out the contents of the anterior abdominal wall along with it, which is called as processus vaginalis. And the communication between the processus vaginalis and the abdomen should get obliterated by 1 year. If it persists, it causes hydrocele or indirect inguinal hernia. Next, you have to know what inguinal canal is, what the boundaries are, what the contents are. What is the content of the inguinal canal? Spermatocord, and in females it is round ligament. And what else? You will tell me the answer to this question in the next class. Okay, very, very important. What are the contents of the spermatic cord? Again, a very important question. Anything and everything about inguinal canal is important. How is inguinal canal relevant here is because the testis actually passes through the inguinal canal before it reaches the scrotum. If it gets stuck in the inguinal canal, it is called as cryptorchidism. Okay, it is called as cryptorchidism. Failure of the testis to descend into the scrotum is called as cryptorchidism, and the treatment is you will have to follow the track of the testis. If it is palpable or not palpable, then you will bring the testis back into the scrotum. Otherwise, what happens if the testis is left over there? It increases the risk of seminoma, the cancer of testis. Okay, then we studied how the development of the male urethra takes place. If the urethral opening is present on the dorsal part, it is called as hypospadias, that is in the inferior part. If it is present on the superior part, it is called as epispadias. Okay, this is all about the development of the male urogenital system, which is very important. You should know all of these basics. Okay, and that brings us to the end of today's class, guys, and I hope you have enjoyed today's class and you've learned something here. And that brings us to the end of embryology also. Tomorrow I'll just take one more session and we can have a complete closure to the topics, because I hadn't done the development of stomach and pancreas. Those two topics are left out, and then we'll give a nice closure to everything. Once we do that, we'll compile everything and I'll give you a nice closure to the topic of embryology. And I hope you have learned, you have enjoyed the series of embryology, and keep studying, guys. I'll see you in the next class. Thank you so much.